Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hi friends, you're listening to the As a Woman podcast. I'm your host, Dr. Natalie Crawford. I'm a fertility doctor, and every single day I talk about fertility. I have this entire podcast just so that you can learn more about your body in a place that feels safe and easy to understand. So no matter where you listen, if it resonates, please share, please subscribe and follow along on your favorite podcast platform, and that just helps get our message to more people. Today, I'm talking about tobacco, marijuana, and fertility. Just yesterday, I was talking to a patient and she said, how am I having such a hard time getting pregnant when there are people out there smoking packs of cigarettes and smoking marijuana and eating Big Macs, and they're pregnant with their 5th or 6th child? And I understand it sounds, and it is, so unfair. But the truth is, we do know that things that you do, choices that you make, can impact your ability to get pregnant. And yes, everything doesn't impact everybody the same way. But if you're looking to have the easiest path to pregnancy, have the lowest chance of infertility, and if you're going through fertility treatments, it's so important for you to understand how some of these behaviors you and your partner might be partaking in, what they exactly do inside the cells in your body. So that's what we're going to be talking about today. And before we dive in, a few housekeeping items. Number 1, you can ask questions, and at the end of every episode, including this one, I'm going to answer some of those questions. Questions can be asked Monday on Instagram at nataliecrawfordmd. Some of the questions will be answered here on the podcast. Some questions will be answered on Instagram on Mondays, and some questions will be answered on the newsletter. Every Friday, there's a weekly newsletter, which is going to give you recipes, updates, questions, fertility in the news, and ultimately a lot of fun freebies coming up soon. So sign up for the newsletter at nataliecrawfordmd.com/newsletter. It always surprises me how many questions we really have. Even though I've given years of content and talked about so many different topics, that there's times I wonder, am I going to have anything left to say on this podcast? But you guys have so many questions. And honestly, I love that you're advocating for yourself. I love that you're trying to understand your body better. And I love that I can try to help you in this journey because I know how hard it is. I've been there myself. So another great way to get your questions answered is to call 657-229-3672. That is the As a Woman voicemail. And on the voicemail, you can leave any question you want. These are my absolute favorite episodes to record because I'm really getting to the base of whatever it is you're curious about. And sometimes you don't even know what questions you have until you hear other people ask. So again, 657-229-3672 to leave your question on the As a Woman voicemail, or you can ask a question on Instagram at nataliecrawfordmd or on the newsletter, nataliecrawfordmd.com/newsletter. So diving in today, really we're talking about toxins and fertility. So often we think about fertility as solely a female fertility facing issue. And I see people every single day who will say, oh, my partner doesn't need a workup. I'm sure the problem is me. But the truth is, it takes 2 to tango. So you need an egg, you need a sperm, and the environment of those gametes dictates the DNA integrity. And it's really quite as simple as that. And that is why when it comes to toxins, so often this topic is hard because toxin avoidance takes an active effort. And some of these toxins are things that are fun or enjoyable or things that we know are bad for us in one way, but we don't really want to connect the dots to what that means about our fertility. Anytime I talk about toxins at all, I always say what my patient asked at the very beginning. Of course, we're all going to have stories of people who did X or Y and still were able to get pregnant. Every single body is different, and your reaction and your response to the environment is going to be different. But if you are looking to have the easiest journey possible to be your healthiest self, if you have infertility and are having a hard time, if you are paying and undergoing fertility treatments, or if you're not having success. Trying to look at where we can optimize outcome is very important. It might surprise you that about 21% of adults still smoke cigarettes. And when it comes to marijuana use, we have about 18% that report marijuana use. And these numbers are probably low because anytime you ask for self-reported behavior, people are hesitant, especially when one of the things you're censoring is illegal in some places. If we want to give a story about why this impacts our reproductive outcome, I'm going to give you a couple. One is a couple that I took care of, and this was many years ago, but they were undergoing IVF. She was ultimately young and had her fallopian tubes blocked, so IVF was the option. And ultimately we said, hey, we should have a really good prognosis. When we did the semen analysis, everything looked fine, so we proceeded on to IVF. And in their IVF, they had complete failure of embryos to develop, meaning we got eggs, the eggs were fertilized, but all of these embryos stopped developing around the day 3 stage. And interestingly, this is where the male genome kicks in. So when you have an embryo, that genome from the egg controls those first few days of development. And then those male genes are going to kick in to keep the embryo going. That doesn't mean that absolutely anything that fails to develop after this stage is due to a male source, but certainly when you see just a halt in progression at that day 3 stage, it's a big red flag that sperm or the DNA integrity in the sperm might be the cause. Now, when this happened, we were really shocked because I had a young patient with a good egg count and tubal factor disease. However, when I went to go meet with them and we reviewed with the lab and I said, hey, this is really concerning about a sperm impact for the DNA, and I ran through the list of potential things that can impact the sperm. Now, we had gone over these in our initial consult. We had talked about behaviors that can impact the integrity of the sperm, and it's really important to know that what you check on a semen analysis is not checking the functionality of the sperm. Because what is a sperm's function? A sperm holds DNA in the head. It has to swim to where the egg is, attach and allow that DNA to enter the egg, and it has to keep the DNA protected along the way. A semen analysis is looking at how many sperm there are. Are there enough to even get to the egg? And interestingly, it takes an army of sperm to all exert enough force to let that one sperm in. So are there enough sperm to do that? How do they move? Certainly if they can't move, they can't get to the egg. And what are the shapes of the sperm? And this shape is also called morphology. So we do see that sometimes, especially lifestyle behaviors or toxic behaviors, can be associated with an abnormal morphology or shape of the sperm. And we do worry that if the sperm is abnormally shaped, can it carry the DNA inside the head okay? But you can have sperm that look normal on morphology, but we're not really testing the DNA inside of them. And there is a test you can do, and it hasn't been proven to be helpful per se in modern IVF practice. And this is called a DNA sperm fragmentation. And I actually like the test. However, it's telling you, what it has been studied to tell you is that if the DNA inside the sperm head is damaged, that you should do IVF with ICSI, which is fertilization where you take one sperm and you put it in the egg. And that fertilization is done in a lot of places pretty standard now, just to have a higher rate of fertilization, to prevent failed fertilization, and to have a more pure sample if you're doing genetic testing. So even though I think the test is helpful and I order it sometimes, it's important to understand the evidence tells us to order this test to try to decide if we should do ICSI. So if you're already doing ICSI, we don't have proof that the test is helpful. That being said, if you have potential lifestyle variables that we're trying to ask if they're impacting the integrity of the DNA despite a normal semen analysis, that might be a case to consider this. And I've certainly had some people be very hesitant to make lifestyle changes. And when we did a DNA fragmentation and we saw that the DNA was damaged, or we saw that there was a lot of inflammation and ultimately a higher risk to have something go abnormal, sometimes that's the push to really get somebody to stop behavior. But if you're willing to stop, if it impacts your fertility, I'm telling you now, it impacts your fertility. Why undergo a failed cycle or have to pay money and have testing done if you're willing and able to go ahead and stop behavior? It turns out that couple who had no embryos develop, the partner actually used marijuana every single night, had a very powerful high-end job, and marijuana at night was part of his routine to calm down, go to sleep so he could get up early and perform his very important job. And he did not disclose that initially. After a lot of talk, we were able to get him to stop, waited a period of time, and redid an IVF cycle. And had a very different outcome. So one, you got to tell your doctor stuff. We can't make recommendations if we don't have the data. Can't make decisions on data you don't know. But you really need to think big picture. They spent an entire cycle of time and money and emotional, physical effort, and we had no embryos to show for it. And had we known, we could have at least had that discussion earlier on in the process. So there's an interesting study. I think most people know that cigarette smoking is bad. And this study showed that 99% of the population knew that smoking could cause lung cancer, heart attack, and pulmonary issues. But 39% knew that smoking cigarettes could cause miscarriage. Only 27% knew that it could cause ectopic pregnancy. Only 22% knew that smoking can cause infertility. And only 17% knew that smoking is one of the top causes of early menopause or premature ovarian failure. Smoking cigarettes decreases your egg count. We have many studies on cigarette smoking and reproductive outcomes. When it comes to time to pregnancy, you had a 54% higher chance of having infertility, meaning inability to get pregnant at 12 months, if you smoke cigarettes versus no cigarettes. And that was for smokers than non-smokers and either partner. So even if you don't smoke but your partner does, that impact was only slightly smaller. So it was still significantly important. You still had a delay in your time to pregnancy if your partner smoked cigarettes. When it comes to menopause, menopause occurs 1 to 4 years earlier in women who smoke cigarettes versus non-smokers. This is dose dependent, meaning the more cigarettes you have smoked in your life and the longer you have smoked, you have an increase in follicular depletion or a drop in your egg count. The chemicals in the cigarette smoke are what is the most impactful thing here. So we see FSH levels higher in young smokers versus non-smokers, and we see that this means you're going to have diminished ovarian reserve, lower AMH levels in a population who has current cigarette smoking. Even if they're undergoing fertility treatments, we're seeing a decrease in outcome. If you smoke cigarettes and you have PCOS and you're trying to use medication like Clomid or letrozole for ovulation induction, you have a lower chance of having a live birth. 80% lower. If you smoke cigarettes and you're undergoing an IUI, an intrauterine insemination, also known as artificial insemination or turkey-based strain, what we see is that smokers who underwent this process needed more medications in order to ovulate, and especially male smoking had a very significant reduction on the clinical pregnancy rate after IUI. And when it comes to IVF, the numbers are pretty striking. People who smoke, either partner going through IVF, needed twice as many IVF cycles as non-smokers, and there was a significantly reduced chance of live birth for smoking patients and an increased risk of miscarriage. Even if you're using donor eggs, so it's not your own eggs, you see a significantly lower chance of pregnancy. 34.1% in smokers versus 52.2% in non-smokers. So the adverse effects of cigarette smoke happen on multiple different levels. It's not just the egg or the sperm, but we see that smokers need more gonadotropins. You have to spend more money on medication. You have a lower estrogen. You get less eggs at the retrieval. You have higher number of canceled cycles, decreased rates of fertilization, lower implantation rates in your cycles, lower pregnancy rates, higher miscarriage rates, higher ectopic pregnancy rates. If you are going through fertility treatments, we are working so hard to get you the best outcome. You don't want any of that. So it could be part of this egg quality issue, could be that the toxins accumulate in the fluid of the follicle. We know that other environmental chemicals can get into that fluid as well. Things like BPA and heavy metals. And when you look at this follicular fluid, that can cause a lot of oxidative stress. So when we look at the follicular fluid, which interestingly, when you do IVF, we do the egg retrieval. What we're doing is we're taking a needle and we're placing it through the vagina into each follicle in the ovary. We're draining out that fluid and getting a test tube of the follicular fluid in the egg. I liken this to drawing blood. So if you can imagine you're getting blood drawn, there's a small needle that might go into a blood vessel. There's a plastic connecting tubing that goes to the test tube where your blood is actually collected. It's very similar to that. We use a small pressure device to suction that follicular fluid out. And each egg is microscopic, grown inside a follicle, and the follicle is filled with fluid. So there's many studies actually looking at the follicular fluid. So whether you said you smoked or not, or use this or use that, they can actually test what's in the fluid of the follicles. And so some of these studies are truly looking at a cellular level of the fluid that these eggs are growing in. So we know that smoking cigarettes impacts your natural fertility, takes you longer to get pregnant, associated with pregnancy outcomes that can be poor, but IVF itself cannot overcome this. And if you've gone into ovarian failure, the door is shut. That time has passed. So it's very important to control the variables that you can. When it comes to sperm, I think this is interesting because studies have shown that concentration, motility, and morphology may be lower in people who smoke cigarettes, but still might be in that normal range. So you might get a semen analysis, tell yourself, well, if it's normal, whatever I'm doing is okay. But we also have evidence suggesting that smoking cigarettes makes it harder for your sperm to bind to the egg. It actually binds to this outer shell of the egg called the zona pellucida. So there has been studies done showing that sperm exposed to cigarette smoke can't actually bind to that zona pellucida. So having a semen analysis that is normal does not 100% tell us that, oh, smoking has no impact. And in fact, some of this data is telling us that smoking absolutely still has an impact, even if you still have a normal sperm count. What is really concerning when it comes to cigarette smoke is what we call the mutagenic potential. So eggs and sperm are your gametes, and we know that the DNA damage inside those gametes can result from many different exposures. This happens when we just think about getting older. You have DNA damage inside your eggs. This is the number one reason why it's harder to get pregnant as you get older, because your eggs are held in a very vulnerable stage of cell division called metaphase of meiosis. Chromosomes are perfectly in line, but very, very vulnerable. And that DNA damage and lack of integrity means that you have a much lower chance of ovulating a genetically normal egg, therefore decreasing your chance of pregnancy and increasing the chance of genetically abnormal baby or a miscarriage. So when it looks at cigarette smoke, though, we see that the proportion of abnormal eggs in the ovary increases directly with the number of cigarettes smoked per day. Linear correlation. Just think about that. If you've gone through IVF or somebody you know has, we work so hard to get every single egg that we can. And we talk about math and equations trying to get to this normal outcome. Number of cigarettes smoked per day, a linear change in the number of normal eggs that you have. That's crazy. And we think that this is because the cigarette smoke toxins disrupt that function of that meiotic spindle. So all of that oxidative stress comes in and it damages the proteins that hold our chromosomes in that perfect order. Therefore, they don't separate perfectly. Interestingly, you also have an increased risk of trisomy 21, Down syndrome, or specifically having a double Y chromosome if one of the partners smokes cigarettes. So the genetic changes due to cigarette smoke are shown. Many people are surprised to know that cigarette smoking is associated with miscarriage and ectopic pregnancy. There's many other placental issues when it comes to not just miscarriage, but also preterm birth, having an increased rate of fetal demise, fetal growth restriction, and that's for both cigarette smoking, but also other forms of tobacco delivery. And when it comes to ectopic pregnancy, we see a huge increase in the rate of ectopic pregnancy in smokers, likely due to abnormal function of the cilia inside the fallopian tube. So in our prior episode, we talked about how the tubes are more than just a highway. They actually help egg and sperm come together and transport that early embryo. And they don't function normal in the setting of cigarette smoke. And in the setting of tobacco, it takes 10 years after you quit to get back to the same relative risk as somebody who's not a smoker. So just think about that. You can quit today, but the damage is going to persist for quite a while. So quitting sooner is better than not. There was a study showing that female smokers who are seen in a fertility clinic have tried to quit smoking up to 3 times in the past and not been successful. So nobody's acting like this isn't a real addiction. And certainly you need to get help if you're smoking, and understanding that there are some medications, things like Wellbutrin or other things that might help you quit this habit that don't have the same reproductive risk that smoking cigarettes do. When it comes to vaping, this is probably the number one thing I'm asked about. I'm always surprised how many of my patients are actively vaping. Vaping includes a battery-powered product, and it heats up and it aerosolizes a solution that has nicotine plus other toxins. And people usually say, oh, this is safer because there's no actual smoking and that it's a bridge to help people quit cigarette smoking. But that is not what I have seen. And this perception that it is safe and smoking cigarettes is not safe is actually wrong, because you're still having aerosolized particles that are toxic going into your body. And so the World Health Organization has said that vaping can lead to an increased risk just of cancer, cardiovascular disease, and adverse reproductive outcomes, just like smoking cigarettes can. And we see that the vaping do contain heavy metals, chromium, nickel, and lead. We also see weird carbons like formaldehyde, acetaldehyde, acrolein, and glycoxyl. So these heavy metals can be endocrine disruptors. We can see infertility from vaping, increased risk of miscarriage, and of course, they do contain nicotine themselves. A lot of the vaping data to date has been in animal studies. Important to remember that fecundability studies, markers of time to pregnancy or your ability to conceive, they often take years to conduct because humans gestate for much longer. However, animal studies, especially with the mouse models, have shown that female mice who are exposed to vapes have a decreased time to pregnancy, which suggests lower fertility and impaired implantation. Exposure to the vape in mice has also been shown to impact the placental function. When it comes to sperm, we do have some human studies showing a decrease in sperm parameters in men who vape versus those who don't. And animal studies have shown that exposure to vape has been also associated with decreased sperm viability, whether or not there was nicotine in the system. So there's definitely something to be said about the toxin exposure and the oxidative stress that isn't 100% nicotine. It is more of the aerosolized toxins that are going into your body. We also see an association with erectile dysfunction in vaping. So we gotta have an erection to get pregnant, friends. All right, let's switch gears and talk about marijuana for a minute. So in 2012, marijuana began to become legal in certain states and territories. Currently in the United States, marijuana is legal in 18 states, 2 territories, and DC. This means that the number of people who at least are acknowledging using marijuana has increased dramatically and almost doubled, being close to 4 million people now. Marijuana use is associated with a longer time to pregnancy and is associated with infertility. A study looking at people's perception of marijuana showed that participants report that marijuana is safe in pregnancy at low doses, poses no risk to offspring, and does not impact fertility. And these are not true statements. The American College of OBGYN and the American College of Pediatricians recommend against using marijuana in the preconception period and the pregnancy period due to risk to the offspring. We see a strong correlation between marijuana use in men and their sperm. Smoking marijuana was associated with lower testosterone levels than non-users. Thus far, all studies that are looking at men from the general population found an association between using marijuana and having lower sperm quality across all parameters. So across count, motility, morphology, concentration, all of them. There was also a recent study looking at preconception use of marijuana by the male partner and the impact on pregnancy outcome, and using marijuana 1 time per week or more. So most people would not consider that to be a huge use, but 1 time per week or more was associated with an increased risk in miscarriage. And that persisted even if the female partner did not use marijuana. So 1 time per week or more, we had more than a double risk chance of having a miscarriage. So marijuana use has been associated with DNA fragmentation in the sperm. So again, everything is coming back to having a higher level of damaged DNA inside the sperm, and that itself is increasing the risk of having a miscarriage. We also see other things that can increase miscarriage, such as having older age of a male partner or testing the DNA fragmentation and seeing that it is more fragmented. But older men also have a higher rate of fragmentation. And then there was another recent study looking at cannabis use while trying to conceive. And this is another cohort study where you just watched people, there was no intervention, looking at their rate of pregnancy and pregnancy loss and live birth rate. The study ultimately had a very low use of reported cannabis, so only 5% of the study said that they used marijuana, which is lower than what we expect the actual population is using. So there likely was some underreporting, which can make the results a little bit harder to interpret. But preconception using marijuana was associated with having more intercourse, so that's good. More sex usually means more babies. But even though there was more intercourse, there was less pregnancy. So using marijuana, but while you're trying to get pregnant, you had more sex, but you got pregnant less. So there's definitely something going on at the cellular level when it comes to cannabis exposure and what it is doing when it comes to your ability to get pregnant. The take-home message is that cigarette smoke, vaping, marijuana use, they should all be eliminated if you're trying to be your healthiest self. You can look at this data and say, so-and-so got pregnant, or this person did this and they still had a baby. And that is all true. But we also have really clear evidence that we have a harder time getting pregnant. And clearly we can all agree that there's cellular damage that is happening. The cell's integrity, the DNA, there's oxidative stress when your body is exposed to these chemicals. And we don't have enough evidence to say, oh, well, gummies are fine, but smoking marijuana is bad. So ultimately, if you are having infertility or going through IVF, trying to add to your family at an older age where male partner has more DNA damage or the egg has more chromosome instability because of the meiotic spindles, it's even more important that you focus in on these lifestyle factors. Good news, even in some of the marijuana studies, is the sperm impact appears reversible upon quitting, but it is important to set yourself up for success and not get behind the game. Now we're going to answer some of your fertility questions, and this is For Fertility's Sake, our weekly Q&A segment. These questions, again, can be asked on Instagram at nataliecrawfordmd on Monday. Some questions will be answered on Instagram, some here on the podcast, and some in the weekly newsletter, nataliecrawfordmd.com/newsletter. You can also call and leave your voicemail question at 657-229-3672. All right, the first question here is, how long would you give Clomid to work? I have PCOS and reduced sperm count. So I think the big key here is that the reduced sperm count, how bad is it? Is it appropriate, though, for you to get pregnant with intercourse, or should you be adding on an IUI into the picture? Or is that sperm count low enough where you should be doing IVF? If the sperm count is suitable for intercourse, usually we want to see a total motile sperm count of about 40 million in the entire sample. If you have PCOS, working means a couple different things. So number one, are you ovulating? You need to confirm ovulation in some way, whether your period comes when expected, or you have an ultrasound, or you use a trigger shot, or you check a luteal progesterone, or you get a temperature raise. All of those are fine, but did you ovulate? That's Clomid working. Remember, Clomid's job is not to get you pregnant. Clomid's job is to help you ovulate. If you ovulate, how long do you wait before you advance care? If everything else is normal, fallopian tubes are normal, sperm count's normal, depending on your age and how many kids you want, 6 months tends to be the maximum. Meaning, if you now have corrected your ovulatory issue, you have normal sperm, open tubes, you now have unexplained infertility, and it's time to advance care. If you have a reduced sperm count, I'm not sure you should be waiting any longer. Do you need to be using Clomid for super ovulation and ovulating more than one egg plus an IUI? Do you need to be doing IVF? What is going on? The next question is, can your AMH change month to month? It actually can, and it does, and this freaks people out in both directions all the time. Thinking, did I get more eggs or did I lose eggs? And then doing the math equation to figure out when that number will be zero. Remember that AMH is made from the cells that surround each follicle. Every single month you have a different number of follicles coming out of that vault in the ovary, and the number is proportional to how many you have remaining. So you have more follicles inside, more come out, fewer follicles, less. That being said, the body's not perfect, and month to month you can see up to a 30% variability. So that's why we typically give a range for your age. If you're age 32, we would expect to see between 16 to 20 follicles. But month to month you have an absolute number. It might be 16 one month, then 18, then 15, then 17. And each month you have a different number of follicles making a different amount of AMH. Therefore, AMH can and does vary month to month. All right, and our last question is, can HCG release before implantation happens after embryo transfer? What's really interesting here is that when you put an embryo inside the body in IVF, you are typically doing what we call a blastocyst transfer, or transferring the embryo at the blastocyst stage. This is a day 5 or 6 embryo. Now, implantation typically occurs immediately within 48 hours of putting that embryo inside. And HCG is not going to be able to be detected until the embryo is implanting. That is how HCG gets from the embryo into your bloodstream, filtered through your kidneys, and into your urine to take a pregnancy test. The only thing important to note here is that if you did a trigger shot, so if this is a fresh transfer or this is a modified natural transfer, meaning you used an HCG trigger shot, that trigger will be detected in your bloodstream before you actually put an embryo inside. So if you took a pregnancy test the day of your transfer, it very well may be positive, but it's the residual trigger and not from the actual embryo. So very, very interesting. The reason why we use HCG for trigger shots is we don't have an isolated LH compound. HCG binds the same receptors as LH. LH is the normal surge that triggers ovulation. So you can use HCG to trigger ovulation as well. All right, friends. Well, I hope you found this episode interesting and learned some things. As always, I appreciate you so much. Feel free to follow along on Instagram at nataliecrawfordmd. Ask your questions on Mondays and follow along on the YouTube channel at nataliecrawfordmd. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.